عليكم ورحمة الله وبركاته. أسعد الله مساكم جميعا. I would like to thank Dentiscope for giving me this opportunity to talk about functional appliances in orthodontics. It's at 3 o'clock, so it's time to start. And those who will be joining us late, I think it will be saved in the account of Dentiscope so that you can watch it later on. Now, functional appliances, in the past, the specialty orthodontics, it was mainly talking about orthodontics, which is teeth moving the teeth with braces or with any different appliances. However, the term orthodontics have been changed to orthodontics and dentofacial orthopedic, which means we're not only moving the teeth, but we are also moving the facial bones, specifically the maxilla and the mandible. We can do this if we start the best time for treatment. Now, it depends on the cause, and it depends on the diagnosis of the case. If the patient is a growing child, which means there is still potential for the jaw bones to grow, then we can either accelerate the growth or restrict the growth. It depends on what we want to do. If the patient is adult, which means there is no further growth, no growth left for him, then we cannot do anything for the bones, for the facial bones. And if the patient has a skeletal problem, it means we have to do braces to align the teeth, but in addition to this, we need the surgeon to help us to move the facial bones into the desired position. So today's talk is mainly for a growing patient. Patients, usually children or teenagers, they came at the right age, and it depends on the cause of the problem. Then we start. Now, let's talk about the ideal. I want to give 1 minute to talk about the ideal occlusion, and then we will see different cases and when is the best time to treat them. Now, this is an ideal occlusion. As you can see here, it's a class 1, midline is on, the mesobuccal cusp in the central groove, overjet, lower anterior teeth is slightly touching upper anterior teeth, well aligned arches, upper and lower. So this is the ideal occlusion. If a patient have something different than this, then it is time to start the treatment. Let's say the patient has a skeletal class 2, like that. Our aim is to achieve this occlusion. So class 2, it means upper teeth are more forward, patient has a big overjet, okay? And I know that you know this, but when you see how does it look into the patient profile, when the patient has class 2, this is the changes that you would like to see at the end of the treatment. Usually class 2 cases, they have deep levimental fold, upper teeth are forward, lower teeth are backward, and your aim is to restrict the growth of the maxilla, advance the mandible forward, and usually this also has a good effect on the patient profile. Now, if the patient has a class 3, usually they have the lower teeth are forward in position like that. It has an effect also on the profile of the patient. So when you move the lower teeth, it improves the facial profile and the lips. Now the patient this is the correction that you see at the end of the treatment. It also improves the facial profile. Here the patient has a concave profile, lower jaw is forward. After you move the lower teeth backward and the lower bone backward, it improves the facial profile. These are, the beauty of orthodontics. If you start the treatment in the right time, it literally improves the outcome and it helps the patient profile. Now, I feel sorry for those patients who came late and they missed the proper timing for treatment. And that's why, as a general statement, as a guideline, according to the American Board of Orthodontics and the American Association of Orthodontics, الجمعية الأمريكية لتقويم الأسنان, they say all the patients, all the kids should be screened by orthodontists at the age of 7. As we all know that patient or the child should see the general dentist by the age of 1, when he's 1 year old, or when the first tooth erupt. But for orthodontist, we like to see the patient at the age of 7. Why the age of 7 is because there are certain malocclusions, there are certain facial deformity that can be only corrected at this age. As the patient grow, as they become like 8 and 9, after 9, some cases cannot be treated at that age, and you tell the patient and to his parents, sorry, wallah, you missed the time, nothing we can do right now, let me see you when you're like 18, and at that time we'll do surgery. Other cases, it's better to be started at treatment just before the growth spurt. Now, let's talk about, we have today I'll talk about 3 dimensions of treatment. The first one is the sagittal, the anteroposterior relationship between the maxilla and the mandible. Now, if the patient has a class 2 skeletal discrepancy, and this class 2 skeletal discrepancy, and as you know that class 2, the problem of class 2 is that it's this. This is the problem of class 2. The patient has the maxilla is forward and the mandible is backward. Now, it depends on the case. If the patient has this class 2 due to prognathic maxilla, the maxilla is forward, then you want to restrict the growth of the maxilla. Now, how do you restrict it? Use a headgear. Now, if the problem in the mandible, the maxilla is fine, it's in the orthognathic position, the problem in the mandible, patient has retrognathic mandible, then you would like to use functional appliances to accelerate the growth of the mandible. Now, I'll show you different photos of headgear. Now, headgear, we have 3 different types. The middle one is the most common type, which is cervical headgear. This retract the anterior teeth, the molars, and it extrude. This is the hypal headgear, and this is a combination of both. I'll show you some videos for our headgear. This is the cervical headgear. Now, this patient has prognathic maxilla. The maxilla is forward. So what do? We place bands and we insert the headgear. We tell the patient and the mom that your child should wear this headgear at least 14 hours per day. Okay, so as you can see, The force is at the first molar, and the force is like that. It's going backward and downward. And what it will do, it will distalize the first molar, and at the same time, as it distalizes, it extrudes downward. So if you get extrusion, you open the bite. You see the patient here has a deep bite. See how is the effect of the headgear. As the patient wears it, there is an improvement in the open bite because there was an extrusion in the first molar, and there was also distalization. So the patient turned from class 2 into a class 1. So this is the profile. You have a deep labimental fold due to the upper centrals are protruded, and this is a normal profile. Now, what is the proper time for this? Usually, it is better to do this just the growth spurt, مرحلة ما قبل البلوغ أو مباشرة ما قبل البلوغ أو بداية البلوغ. And how do we know this? In the past, we used to take hand and wrist radiographs to evaluate, but nowadays we have different way of doing it. Every patient comes to us, we take a lateral cephalometric radiograph. So instead of exposing the patient to a hand and wrist radiograph, as I take a lateral cephalometric radiograph, I evaluate the vertebrae bones of the patient. We look at the cervical vertebrae number 2, number 3, and number 4. As you can see, they are there in the radiograph, so I don't need to expose the patient again. Now, how can I read these radiographs? There is a study by Dr. Bashetti, and he said that these vertebrae go into 6 stages. Stage 1, you see the inferior border is flat of the second vertebrae. It is flat in the third, it is flat in the fourth. This, when the patient at this stage, it means that the patient has 2 years of treatment before he goes into the growth spurt. So when a patient is in this stage, I tell them, it's too early, let me see you after 2 years. Stage number 2, when the second vertebrae has concavity here, while still 3 and 4 it has a straight line. So at this stage, I tell the patient, well, it's too early, but I can see you after 1 year. So here is 2 years, here is 1 year before the growth spurt. Here, this is the start of the growth spurt, when second and third vertebrae has concavity. You see the concavity? It was flat, then it became like that, okay? This is the best time to start the growth modification for class 2 cases. Now, 4, it is at the end of the growth spurt. There is still some growth, but it is minimum, it's not a lot. When a patient comes at this stage, I still treat him, but my expectation is not as ideal or as much as stage 3. Stage 4, you see the concavity in the second, third, and fourth. And stage 5, you see the concavity in both of them, but here it was rectangular horizontal. Here it becomes square. You see the distance from here to here. So هذه زي المستطيل بالعرض in this stage. Rectangular horizontal. Here it's a square. These are like almost the same. And this means that patient is done 2 years after the growth spurt. Sorry, it is 1 year after the growth spurt. So when the patient at stage 5, it's too late. Now stage 6, it is vertical rectangular, مستطيل بالطول. This part, it becomes very long compared to this part. And at this stage, patient is more than 2 years after treatment. When a patient comes at this stage, it's too late. And you can see some examples. This is stage 1, flat, flat, flat. This is stage 2. You see, it's easy to remember it because the second vertebrae, when you have concavity, it's stage 2. This is stage 3, concavity in 2 and 3, but 4 is still flat. Stage 4, concavity is there in 2, 3, and 4, and you see it's not too long. The vertical part of the vertebrae is not too long. Stage 5, this becomes long and now it's like a square. And stage 6, it's vertical rectangular, مستطيل بالطول، مستطيل بالطوليا صارت طويلة، فهي مستطيلة بهالشكل مش بهالشكل. So this is regarding the timing of the treatment. This is the best time. If you can see the patient at this age, this is the best time to treat class 2 cases. Now, I said in the cervical headgear when the patient has a class 2 due to prognathic maxilla. This patient has a good overbite and overjet. A good overbite, I don't need to extrude. So these cases we use headgear, but it's a combination of both. So I don't want to extrude the first molar vertically. I don't want to extrude it. I just want to move it backward, okay? And while I restrict the growth in the maxilla, the mandible grows freely. So again, this is how you treat a prognathic maxilla skeletal class 2. Now, let's say that the problem is not from the maxilla, the problem is from the mandible. Patient has a normal maxilla and the mandible is recessive or weak, or it is retrognathic mandible. So what do we do in this case? Now, this problem here, we have multiple appliances. We have a lot of appliances. It depends on your preference. It depends on the lab support you have. It depends if you like removable or fixed appliances. And the best time to treat this, as I said, just before the growth spurt. So this is an appliance. It's called Advanced Sink. The beauty about this appliance, it's very small and it is fixed. It's something that is you cement on the crowns. Usually patients at this age, they have a problem with cooperation. So once you use something fixed to their teeth, you eliminate this problem. Now the only problem you have is that the patient tolerance. They have to accept it, they have to keep it clean, they have to keep it safe, they should not play with it, okay? But they are good because they are fixed. And there are multiple appliances, okay? Now, there is the other one, the Herbst appliance. It's bulkier and bigger. It needs a lab support. And it has a band and a TPA in the upper, lingual holding arch in the lower. For me, I use this a lot. I like it because it gives too much force and it helps skeletal correction of the mandible. It stretches the mandible forward and it advances the lower teeth. Now you can see the correction that it does to the patient profile. Now, look at the differences. This is, طبعا here it's not really clear, it advances the mandible forward. It accelerates the growth of the mandible. Now, class 2 corrections. It does not only advance the mandible forward, but it also restricts the growth of the maxilla. So this is important. It has headgear effect. So you see here, it advances, it moves the mandible forward, but for the upper, it restricts the growth of the maxilla. So the maxilla is not growing forward. Usually you get a distalization of the first molar backward. Okay. We have another appliance. We have many appliances for class 2 correction. This is we do, also I use this with braces. After I put the braces on and I reach a heavy wire, this wire has to be heavy to hold the forces appliance. And you see the effect here. As the patient closes, this is exactly what I'm talking about. The mandible goes forward, the maxilla goes backward. Okay. So it's very good appliance. Look at the central incisor. It goes backward. Why? Because you're pushing the 6 backwards, so the anterior teeth goes backward as well. Okay. So this is the forces appliances, and there are many appliances that we use for class 2 correction. Now, there are other doctors who like to use removable appliances. Like, you know, the bionator appliance. Such appliances requires a lab support. You need a good technician. The problem with them is they are bulky, and I used to use these appliances, the removable appliances. I know that there are many orthodontists in the world that use these removable appliances. I don't use them because I had difficulty with my patient. I give them the appliance. After some time, they came back. It is either broken, they misplace it, they don't know where is it, they lost it, they didn't lose it, they don't use it, they forget to put it on because they take it out at meal time or like at brushing time, and they don't put it back on. But it is there, and there are different designs, different appliances. One of the common appliance is the twin block. But I don't see it here. I didn't see it, but here. We'll look for it. This is a good appliance, the twin plug appliance. Now, what is the beauty about this appliance? It comes in two pieces, so it's not as bulky as the one before. You get the upper part, you get the lower part, and it helps in 2 directions. First, the patient cannot bite, so he has to advance his mandible. So he's using his muscles to advance the mandible. The fixed appliances, patient is not using his muscles. As he closes, the appliance pushes the mandible forward, so it stretches the condyle, and this is something that I want to talk about. This is the idea behind it. Now, you see, this is the head of the condyle, this is the mandible, and this is the glenoid fossa, or sometimes it's called the mandibular fossa of the temporal bone, because this is the temporal bone, and this fossa is the mandibular fossa of the temporal bone, and this is the articular eminence. Now, this is the lateral pterygoid muscle. When the patient advances his mandible forward, the condyle is not resting at the glenoid fossa, it's being pushed forward. There is a stretch in the condyle. The head of the condyle is a center for growth for the mandible. So as the condyle is being stretched from the fossa, it's like here at this position, there is too much force, tension, في شد في سحب على الhead of the condyle من المسلز that are attached to the head of the condyle. So there is an acceleration of the growth of the mandible. Now, some studies, they have proven this, that the length of the mandible has become longer when you use functional appliances. There are studies that say that no, the length of the mandible is the same, but you have a dentoalveolar compensation, that the mandibular bone, the dentoalveolar bone in the mandible is being forwardly positioned, while the dentoalveolar bone of the maxilla is being distally positioned. But anyway, either you get a true growth in the mandible or a dentoalveolar changes. By the end, you get a class 1 dental relationship. Okay. So this is the twin plug appliance that I was talking about. As you use it, patient uses his muscles, and this is what you get at the end of the treatment. Now, it also has a good part because it opened the bind, but this video did not show it. But twin plug also increased the vertical dimension. If the patient has hypo mandibular plane angle or decreased lower facial angle, the twin plug opened the vertical dimension of the patient. Now, I talked about class 2 cases. Class 2 cases, if the problem is in the maxilla, we restrict the growth of the maxilla using a headgear. If the problem is in the mandible, we use different appliances, whether it is removable, whether it is fixed, to advance the mandible forward. Yes? I need half an hour. So that's the problem of the patient if they have a skeletal class 2. Now the problem, if there is skeletal class 3, the timing for this patient is from 7 to 9 years old, because the maxilla, as it is attached to the zygomatic bone, it's still loose. There is still cartilaginous bone between the maxilla and the zygoma. You still can advance the maxilla forward. And this video that I will show you right now, it's very important, and I use it a lot. And what I have seen, that here in Saudi Arabia, we have many class 2, we have many class 3 cases, and usually it runs in families. Now, this is my patient. It's a skeletal class 3. The problem is due to retrognathic maxilla. The maxilla is backward. Patient has a negative overjet. Here. Most of the time, as I advance the maxilla, I don't only advance it, but I always expand the maxilla. When you expand the maxilla, the output, the result is much better. So this is what we do with the patient. This is cemented on the band. There is a band and a hook, and it is fixed on the patient. Now, this is the face mask that the patient should wear. My problem with this face mask, it is removable, so patient should wear it. For how many hours? Minimum 14 hours per day, not less. And I always tell them, waladkum or bintukum should put it on after school. So he comes from school, eat his lunch, brush his teeth, put the appliances on. And all the time, until it's dinner time. Dinner time, take it out, eat your dinner, brush your teeth, put it on, and sleep with it until you wake up in the morning. So when you wake up in the morning, you're gonna go to school, that's the time you take it off. But then after you come back from school, you put it on. During the weekend, put it on all the time. When it's summer vacation, put it on all the time. And this is sometimes, I think it's a good opportunity to use it at summertime when there is no school, because if the patient wears it all the time, we can achieve a very good result within like 5 to 6 months, depends on the case, of course, and the severity of the case. If the patient is not wearing it all the time, regularly, for enough hours, sometimes it may take up to one year. And some patients, they don't wear it, and the problem is that, we get average result, mediocre result, not the best result that I wish for. So this is the reason why we said we want to see the patient at the age of 7. In case they have this problem, we use this appliance. Now, look at the maxilla and look at the upper central incisor, how they move forward as the patient put it on. There is a force. You put a force on the first molar, the force will be transmitted to the maxilla and it will advance the maxilla. Most of the time, we don't settle for a correction of post of class 1. No, we want the patient to finish into a class 2. This is overcorrection. If you finish the patient class 2, then because sometimes after you remove the appliances, the maxilla still has a deficient growth, the mandible will grow forward, and then patient will have again a skeletal class 3. So always better to overcorrect. So for me, this is not enough. I stop when the patient have 5 millimeter overjet. I want to have overjet, big overjet, as an overcorrection. Okay. So, and this is the profile of the patient after the treatment. Now, what do you see about the profile? Patient had a concave profile and he has now a normal profile. Okay. You see the difference between the profile here and there? This is after treatment. Now, let's say that patient has class 3, but the problem with the class 3 is not in the maxilla, it is in the mandible. There is an appliance called chin cup. But I don't use it. Why we don't use it? Because studies have shown that you cannot correct it. If the patient has the problem of class 3 and the problem is because in the mandible, he has a prognatic mandible, especially when there is a downward growth of the mandible. It's not only prognatic, but also it goes downward. They are very rare cases, but when I see them, usually there is no enough force and no appliances to correct. It has been tried on monkeys and they were successful, but the problem is they had it on monkeys 24 hours for a long time. Our kids will not wear it 24 hours all the day, and the problem is sometimes it affects the condyle because you're pushing the condyle against the mandibular fossa of the temporal bone. So that's the skeletal correction. Now let's talk about expansion. We can expand when the patient is still young, before growth or during growth, but usually after that it's difficult to be achieved. Now, this is a kind of expansion that I have. I like this hierarchical expander. I use this most of the time. I don't extend, my expansion goes from here to the first premolar, that's it. And I don't go all the way, but this is the video that we have, but we don't go all the way to here. And we ask the mom or the father to expand, to turn this appliance 1 turn per day, okay, for 4 weeks. So after 4 weeks, you have turned this 28 turns. Each turn give you a half millimeter. كل turn تعطيك ربع ملي. For 28 turns, it's 7 millimeter. So there are different kinds. You have 7 millimeter, you have 9 millimeter, you have 11 millimeter jack screw. It depends on the case. After you expand, you see this space, and we tell the patient, you will have this space. If you have it, don't worry, this is a sign of successful expansion, okay? Now, there are different ways. We have the slow expansion, we have the semi-rapid expansion, and we have the rapid expansion. The rapid expansion you turn twice per day. يعني تقول للمريض أسوي مرتين في اليوم. Slow expansion you ask him to do it twice per week. مرتين في الأسبوع. Semi-rapid expansion, that's what I do and I prefer, which is 1 turn per day. So after like 4 weeks, you have achieved the proper expansion. Now, this is not the only way to expand. You can use different appliances, but I like this because it gives me more predictable result. You can use a quad helix, and this uses in a young age. Yani 8-9 years old, you can use this. Okay, it's less force than the Hyrax expander, and this you don't need the cooperation from the parents. They don't have to turn anything. You just activate it, cement it on, and you get a proper expansion. Now, I talked about the skeletal, the sagittal part, class 2, class 3. Now I talked about the expansion. We try to avoid expansion in preschool children. 5 and 6 years old, they are very young. Sometimes if you expand and you do rapid expansion, you get a facial deformity. You may break the nose for them. So you don't use a rapid expansion in very young kids. If they are like more than 7, 8, 9, I do slow expansion with quad helix. And I do it for 2 reasons. When you expand, you have enough space for all the teeth to erupt, because neuromaxilla, they will have crowding. There is no space for the teeth. And because sometimes they may develop a shift. And as they grow and they have a shift, they will grow with the shift with them. We cannot use this in adults. I use the Hyrax expander. You know, the maximum age for boys is like 14. The maximum age for girls is like 13. After this, the more you expand, you are not gonna get a skeletal correction. You will get dental. The teeth will tip. The posterior maxillary teeth will tip. So basically, you're not opening the suture. The suture in the middle, the mid-palatine suture will not open when you use the Hyrax in adults, because this suture have closed. You have not. Okay, so that's the only question I have. Okay, so you cannot do it on an adult. There are some studies who have done expansion on adult, but I don't recommend doing it. This is one kind of expansion. This is Haas expander. He add to it an acrylic, and he uses it in adult. But the problem, sometimes you get gingival ulceration and inflammation from the palatal tissue. Now, let's say our patient is adult. He came with very narrow maxilla. What can we do for this? We can expand, but with surgery. Some patients, they come to me, they're adult cases, they're adult, I want to expand, I cannot do it for them. So what I do, I cement the expander, and then I send them to the surgeon. Now what does the surgeon will do? He will go from here, and he will drill. He will not cut this tissue, but he will go from inside, from the labial side, and he will use his chisel and mallet, and he will dig all the way. يبدأ يحفر لما يوصل هنا. So he breaks this suture. There is a suture in the middle. He breaks it, and not only this, he breaks the suture between the maxilla and the zygomatic bone. The suture here is cartilaginous. After the patient after he finished growth spurt, it's not gonna be cartilaginous anymore, and it will be ossified bone. So he cuts this suture. Let me just show you what I mean by the suture. Mid-palatine suture. So this is exactly what I'm talking about. This suture is cartilaginous, but as the patient grows into adulthood, it will become bone. This is what we aim for. You see, after expansion, you break the suture. You can see it, it's broken. You see the radiolucency, okay? Now, about the sagittal and the expansion, the third dimension is the vertical. What is the best time for vertical? It's just like class 2 with the growth spurt. And what we do, we use a bite block. Let me see if I have a bite here. This is a different kind of expansion. You see, this is the problem with why we start early for kids when they have a crossbite. They may have a shift. As they close, they have a premature contact, and then they shift while they open and close. That's why it is better for them to treat them. If you don't treat them early, they will have a facial asymmetry and they will grow with it. Now, this is the bite block that I'm talking about. You have acrylic coverage that covers the teeth. Now, what it will do for the patient, as you expand, it will also intrude the teeth. When you put a bite block or bite plane between the patient, this is the steps. You etch, rinse, and then you apply your bonding agent on the teeth, and you place resin cement or glass enamel cement on the acrylic, and then you cement it on. You remove the excess. Now, the patient can start expanding. So for the vertical part, the best time for it is to do it at the growth spurt. So like class 2 cases and the vertical cases, the best time to treat it is the growth spurt. Now, the last thing I want to talk about is Invisalign. Invisalign usually, not usually, they are meant to treat the teeth. They are used to treat the teeth, but recently they have something new, which is the Invisalign treatment with mandibular advancement. They have added this part. You see this extension and this extension. So this works exactly like a twin block. So this twin block, as the patient wears it, he will have to advance the mandible. So the patient will, if you're using a twin block or Invisalign, he'll put the Invisalign on, and then he will not be able to bite. He will have to advance his mandible forward to bite. So as you advance the patient's mandible forward, you accelerate the growth. There is a stretch in the condyle, so there will be a growth in the condyle. So basically, this is the main things that I wanted to talk about. Functional appliances. I had few questions. The best timing, I told you, it's just before a growth spurt, unless it's a class 3, when the patient is very young, from 7 to 9 years old. How to minimize tipping as you use class 2 correction. You advance the mandible gradually. You don't advance the mandible all the way. Let's say your patient have a 10 millimeter overjet. You increase it, like you correct it 5 or 6 millimeter, and then you go 1 millimeter every month. Sometimes you can do capping on the anterior teeth with removable appliances to prevent the tipping. Does general dentist can do it? I don't recommend general dentist do the surgical part, the class 2 corrections. I think they can do expansion with a quad helix or with Hyrax if it's minor cases. And I think they can do it if they have orthodontists in the clinic who can be around if they need any help, or to supervise, or you discuss the case with the orthodontist before you start the treatment. I always think that orthodontics is challenging. There are difficult cases. Sometimes the prediction توقعاتك مع المريض تختلف. Some patient you think that with the growth and the appliances you will get excellent result. You see after treatment that you did not get as you were expected, and sometimes your patient may grow further. يعني class 3 cases when you're trying to correct it, مشكلة إنه patient become class 3 more, especially if he has a prognathic mandible. You pull the maxilla forward with the face mask, but the mandible is also growing forward, so it becomes a complicated case. Now with this, I have finished all the things that I wanted to talk about for functional appliances. Are there any questions to answer before I close? And I hope that this talk was beneficial. Functional appliances, I think it's an excellent tools that we can use as an orthodontist to help our patient with. The problem, if we miss the timing, there is a best timing for the treatment. If we miss it, we miss it. And then what is left for the patient is either orthodontic camouflage, where you just extract some teeth, or maybe the surgeon can help us with orthognathic surgery. I would like to thank Dentoscope for this opportunity. I wish you all the best, and if there is any questions, I can answer it through my account on Instagram or Twitter. Thank you all. Assalamu alaikum wa rahmatullahi wa barakatuh.